So hopefully this won't engender as many revisions. Let's see. Very good. Thank you. As you can see, my first time at the podium. First of all, I want to acknowledge and let those persons who don't know who the members of the Childhood Adolescent Immunization Schedule work group are. So they are myself as the chair. The members are Ms. Cynthia Pellegrini, Dr. Allison Kemp, and then our liaison representatives are from the AAP, Dr. Cody Meisner, from the AAFP, Everett Schlam, ACOG, Jenny Yost, and Patsy Cinchfield from NAP. We're indebted, of course, to our consultants and most especially our CDC lead, who's Dr. Raymond Strickus, and then the consultants that are shown on the right side of your slide. So I want to remind the members of the committee why we're looking at this and why we're voting on it. I want to remind you all that ACIP approval of the proposed schedules is necessary prior to its publication in the MMWR of January, February 2015. Also, prior approval is necessary before our partner organizations, the American Academy of Pediatrics, American Academy of Family Practitioners, or Physicians, excuse me, and the ACOG, American College of Obstetricians and Gynecology, also approved the proposed schedules prior to the 2015 publication. Lastly, keep in mind that we are not establishing a new policy. These are actually shown in the annual schedules, which reflect the recommendations already approved by the ACIP. So for the remainder of the presentation, Dr. Strickus will discuss the proposed edits to some specific vaccine footnotes as well as to the catch-up table. These edits are intended to improve the readability and utility of the schedule and hence to translate the respective ACIP recommendations into a language that's easy to interpret by the busy healthcare provider. This year, only a few vaccines schedules have required attention. The ACIP members have these in your slide binders, as well as on the meeting website. In addition, on the website are the full set of footnotes for your review, as well as the catch-up schedule, the revised job aids for the DTaP, Hib, and pneumococcal vaccines discussed at the last ACIP meeting. These latter documents will be published, by the CDC, and while they don't require the ACIP's approval, we request that the ACIP review them in the next few weeks to assure that they're consistent with the current Childhood Adolescent Immunization Schedule. So now let me turn this over to Dr. Strickus, who will take us through the proposed slide edits and schedule.
Thank you, Dr. Romero. And when I neglected in advising you that the website referred to is the SharePoint site that ACIP members have access to, but it is not the public website at present. So here is Figure 1, the age-based schedule for draft schedule for 2015. The changes proposed here are to highlight the different recommendations for influenza vaccination for children for number 1, live attenuated influenza vaccine beginning at 2 years of age, and number 2, with a break at 8 years of age, up to when children may need 2 doses of influenza vaccine and after which they require only 1 dose of vaccine. Therefore, the new age groupings have been created for 7 to 8 years and 9 to 10 years to accommodate these changes. I realize those are parsing finely, but we thought they may be useful to the practitioner. This is Figure 2, the catch-up schedule. Let me walk through the proposed changes here. For Hib vaccine, in the dose 1 to 2 column, we only change the language to refer to a dose administered before the first birthday which seemed clearer to us than younger at age 12 months. In the Hib second to third dose column, we define more precisely which Hib vaccines are to be considered for a dose to be given 4 weeks after the second dose, and those are PRP-T vaccines, that is Actib, Penicell, or if it's an unknown vaccine, it might be either of those, and so unknown vaccines are named as well. For an interval of 8 weeks between these doses, and to be the final dose in the Hib series, we deleted what appeared unnecessary, where it stated regardless of which Hib vaccine used. We also defined for children 12 to 59 months of age that they must have received a second dose before age 15 months to allow completion of series in 8 weeks' time with one more dose. And lastly, we deleted some language in the last category to read both doses were PRP-OMP vaccines, and again used before the first birthday instead of younger than 12 months. In the Hib dose 3 to 4 column, because any child who received 3 doses of any Hib vaccine before 12 months of age should receive one more dose, the vaccines named in the strikeout section were deleted, and timing of the receipt of vaccine was deemed necessary to say only that it was given before the first birthday, that the 3 doses, rather, were given before the first birthday. For pneumococcal conjugate vaccine, the dose 1 to 2 column, there were minor wording changes. Again, we're using before the first birthday, and the word was administered before the word administered, to be clear in the second segment that's highlighted there. In the dose 2 to 3 column, language was modified at length to better adhere to the 2010 routine childhood immunization recommendations. Dose 3 should be given 4 weeks after dose 2 if the child is younger than 12 months of age, and the previous dose was given before 7 months of age. Dose 3 is the final dose, should be given 8 weeks after dose 2 if the previous dose, that is the second dose in the series, was given between 7 and 11 months of age, and this third and final dose should be given once the child has reached 12 months of age or older. Or if the child is already 12 months of age or older and received at least one of 2 previous doses before the age of 12 months, they can complete the series with the third dose at that time. In the Tdap section, wording was simplified, again using before the first birthday, and we deleted unnecessary language where we've already defined the TD or Tdap dose as being the final dose in the series up above in the language you see there. The last TD-Tdap edit was to again say in a dose 3 to 4 column before the first birthday rather than age 12 months, before age 12 months. The minimum age for dose 1 for hepatitis A, hepatitis B, polio, meningococcal, MMR, and varicella vaccines is not relevant for children who are already 7 years of age in the catch-up schedule, so we indicated these as not applicable for those vaccines or NA. And in the varicella section, we deleted some extra language where it says person is, instead saying 3 months if younger than age 13 years, and so on. Let me move on now to changes proposed for the footnotes. In footnote 3 for DTAP, the language presently in the general recommendations on immunization was added, which indicates children who had already received the 4th dose of DTAP at age 12 months can have the dose count if the dose followed the 3rd dose by at least 4 months, provided the child's already 12 months of age. So this change was to facilitate retrospective review of vaccine and being up to date, not a recommendation that children should routinely get the dose 4 months when 6 months is really the minimum interval acceptable. In the pneumococcal conjugate vaccine footnote, it's footnote 6, we added language to follow more closely the language in the 2010 recommendations for high-risk children 2 to 5 years of age, that they should receive 1 dose of this vaccine if the child had received any incomplete series of pneumococcal conjugate vaccine, whether the 7 or the 13 valent, and also that such children should receive 2 doses of PCV13 if they had received fewer than 3 doses of any conjugate vaccine in the past. And then, again, that's verbatim from the 2010 recommendations. In the influenza footnote, the only changes were to update it for the 2014-2015 season, update the references, and to point to the 2015-2016, one should follow current dosing guidelines and recommendations by the ACIP that are applicable for those in the 2014 recommendations or those currently available. There were extensive wording changes, although the meaning is meant to be the same in the meningococcal footnote, which you see here. The editing here was done to identify better state the dosing schedule for high-risk infants and children for the 3 different vaccines. We stratified these by condition, and this is the one for children with anatomic or functional asplenia. And the only new language is here that was in the recommendations published in June of this year is to talk about use of Benveo in children 7 months of age and older, indicating they need only two doses of that vaccine. The other language is simply stratifying by vaccine and then by age of the children. And a similar restructuring was done, although the language is in parallel with each vaccine discussed separately for children with persistent complement component deficiencies. Otherwise, the language echoes what was there before, but again, stratified by the type of vaccine. So, as Dr. Romero said, I'll remind you that we request your input, and we'll take the revisions that you give us, go through CDC clearance, and send it to colleagues at AAP, AFP, and ACOG by January 1, 2015. We hope to publish on our website with a notice in the MMWR in January or at the latest February, as well as expect publications in Pediatrics, the American Family Physician, no later than February. And I want to thank the many subject matter experts at CDC, as well as colleagues on the working group, too many to name here, who worked extensively on the 2014 schedule as well as on this 2015 draft. And I want to thank colleagues in our branch, as well as particularly Akiko Wilson, who did the graphics for this presentation. And so I leave it now up to the committee for questions, clarifications, and if you deem appropriate, a vote on the schedule.
Thank you, Dr. Strickis. Open it up for questions from the committee. Dr. Lair.
When I'm looking, I'm not sure what page it's on, but you're in the tetanus diphtheria dose 3 to 4. Your box that has the correction is correct, but on all the other pages it says if first dose of DTaP D2 is administered, if first dose of DTaP is administered. So I think that needs to get corrected on the final copy.
All right, thank you.
Ms. Groom.
Thank you. Just a comment. I just want to say hallelujah for the changes to the HIB language. I think that's going to be incredibly helpful. Thank you so much.
Let me thank Elizabeth Breer and our colleagues who work on HIB regularly, because that's to whom they should be attributed, but on their behalf, thank you.
Dr. Pickering.
Yeah, Ray, I haven't read all 7 pages of the footnotes lately, but just to re-stress, your changes before the first birthday and younger than 13 years of age really clarify things. But as you go through, make sure that you don't use any dashes between the ages, like 6-23 months, because most people will differentiate. Some people will say 2 and some people will say through, and it's very confusing. So I noticed 1 or 2 in here I'll give to you, but as you go through for the final reading, if you could modify and eliminate those dashes, it would make it a little more clear. But you've done a remarkable job.
Thank you. We will do that.
Other comment? So it appears that the work group has done a very good job with the revisions. Do we have any motion for, first of all, do we feel that we're at a point that we could move ahead with this? I see a lot of nodding. Do we have a motion? Dr. Rubin, a second. Dr. Kemp. Further discussion? This is your last chance. Okay. Seeing none, we'll go ahead and start. This is always difficult for me to visualize, but Dr. Vasquez, and go clockwise. That will be to you, Dr. Bocchini.
Vasquez, yes.
Bocchini, yes.
Riley, yes.
Camp, yes.
Karen, yes.
Balanja, yes.
Harrison, yes.
Romero, yes.
Ruben, yes.
Bennett, yes.
Tempty, yes.
Pellegrini, yes.
With all this peer pressure, Reingold, yes.
As such, the motion carries unanimously with 13 votes in favor and 2 absent from the meeting. Thank you very much, Dr. Strickus
Thank you.
and Dr. Romero. I need to turn back to my schedule. It is, we're actually ahead of time. Should we take a break here, or we could? No, let's go. Keep going. I can't. No, I got. If Dr. Riley is up for it, we could have you come up to the podium and introduce the adult immunization schedule.
Good afternoon. I'm filling in for Dr. Harriman, who is, as you've heard, lending her expertise in West Africa. I think before I start, is Chris Sheedy here to give us a quick update on the... No, she'll do it after? Okay, all right. Sorry, I thought that Chris was going to join us so that she could show us some of the new communication materials on adult immunization. So hopefully she's on her way? Okay, all right. There she is. I don't want to steal her thunder, so.
Thanks, Laura. Hi, thank you for letting me have just a minute. I wanted to call the members' attention to a folder of materials that we passed out to you. We wanted you to see and have some of the direct-to-consumer adult immunization materials that we put together, including a few of our posters and flyers, as well as some of the materials that we've done for clinicians, specifically the series on the adult standards. I also wanted to mention that CDC is currently working with the IAC and Medscape to develop a series of features on adult immunization standards, excuse me, to cover assessment, recommendation, administration, and referral and documentation. The assessment features are available online, and the recommendation feature should be available soon. This feature will include case examples with common questions from patients about various adult vaccines and video vignettes modeling how to answer those questions clearly and succinctly. So just wanted to give you a heads up about these materials, make sure you know what's available and what's in the pipeline. And that's it, Laura. Thank you.
Thank you. Oh, there's a question.
Wonderful materials. Are they available in Spanish?
Thank you. So we do have a couple of the pieces currently available in Spanish, and we're going to be working to make more of them also available in translations as well. Okay. Other questions? All right. Thank you so much.
Okay, so I'm going to press forward as everyone was asking for. So this is the Adult Immunization Work Group, and I'd like to acknowledge all of the people who make this group work, and it's a very interesting process that is gone over very, very carefully, and we thank all the representatives as well as the consultants for their work. And obviously, we greatly appreciate our fearless leader, David Kim, as well as our former fearless leader, Carolyn Bridges. So just as a reminder, ACIP, as you know, updates the adult immunization schedule every year, and this represents and summarizes all of the existing ACIP policy. The group meets monthly and goes over, along with consultation from our experts, to recognize changes over time. The updates approved policy changes from additional ACIP meeting on August 13th, and those published in the MMWR on September 19th were discussed in great detail and reworked multiple times, which hopefully you guys will see shortly. The 2014 adult schedule is also approved by ACP, AAFP, ACOG, as well as ACNM. So now I'm going to turn this over to David Kim.
Thank you very much, Dr. Riley. Before we get started, I just want to mention that our ACIP representative lead, Kathy Harriman, as you know, as you got the information earlier, she was deployed to West Africa, or we thought she deployed to West Africa. She was going through some training in Belgium, and recently she broke her foot. Unfortunately, and that prevented her from deploying to Africa. So she's now back in California, and we certainly wish her a speedy recovery. So, in a nutshell, this is what we are faced with in terms of revising the 2015 Adult Immunization Schedule. We are doing three things. We did three things. First is redoing Figure 1, and basically that meant we replaced the purple bar, which basically means it's recommended if there's risk involved, with the yellow bar, and that's we are recommending that. ACIP is recommending that for PCV13 for adults age 65 years and older. Along the way, because these figures are accompanied by footnotes, we needed to add PCV13 for adults age 65 years and older, just as the recommendation was made in the extra session in August for ACIP. And our charge was to basically make it as user-friendly as possible. So the work group reformatted the footnotes from vaccine-focused approach to a patient-focused approach. And lastly, the contraindications table, we added changes associated with LAIV and IIV in the contraindications and precautions. So on that last point, on the contraindications, those changes were based on the recent MMWR article that summarized the ACIP recommendations on seasonal influenza vaccines that was published in August 2014. And in it, there were wording changes in contraindications, and we adopted those changes. The first adoption being the inclusion of severe allergic reaction, that is anaphylaxis, to any component of the vaccine or to a previous dose of any influenza vaccine for LAIV and IIV as contraindications. In addition, ACIP recommends that LAIV not be used in the following populations, and we included the material that was present in the past before: pregnant women, immunosuppressed persons, persons with egg allergy, and children with asthma or who've had wheezing episodes within the last year. We also included other changes in contraindications and precautions, and specifically we included the switch from contraindications to precautions of chronic health conditions. So looking at the 2014 Adult Immunization Schedule, the recommendations that are currently in place, we have three footnotes, each representing a vaccine, PCV13, PPSV23, and revaccination with PPSV23. So and in terms of population group, we divided them into two age groups, one of greater than or equal to 19 years of age, and those adults who are older than 65 years, 65 and older. The recommendation, the previous recommendation of age 65 years and older needing to receive one dose of PPSV23 obviously was in place. And I wanted to specifically bring out the younger age group, the 19 years old and older, because the common feedback that we as a work group get from folks within CDC, folks outside of CDC, from anybody who reads the ACIP recommendations, was that it's complex. And I think Dr. Frieden mentioned this morning that the pneumococcal recommendations, pneumococcal immunization recommendations are complex. So that complexity comes from the fact that immunocompromised adults need PCV13 and 2 doses of PPSV23, and the interval, given that we have 2 vaccines, and the fact that they need to get both, we have different combinations of possible delivery, and the interval between those vaccines are different. So, for example, PPSV23, you need to wait at least 1 year before you're given PCV13. And PPSV23 to another dose of PPSV23, you need to wait at least 5 years. And to go from PCV13 to PPSV23, the interval is at least 8 weeks. So that makes things rather complex. On top of that, if an adult has functional or anatomic asplenia, then that person gets also 1 dose of PCV13 and 2 doses of PPSV23, but certain other conditions like CSF, cerebral spinal fluid leaks, and persons with cochlear implants, they only get PCV13 and 1 dose of PPSV23. Persons with chronic health conditions such as heart disease, less hypertension, kidney disease, and others, they get 1 dose of PPSV23, and a population that constitutes a large segment of the U.S. population, smokers and residents of long-term care facilities, they get 1 dose of PPSV23. So it is a complex schedule given the scheduling and interval between pneumococcal vaccines with 2 different vaccine types. So we had quite the challenge in trying to incorporate the pneumococcal vaccination recommendations in the 2015 adult schedule, because with the addition of the PCV13 for persons 65 years of age and older, the complex set of recommendations became even more complex. So depending on age and conditions, I'm going to point out some of these that are kind of obvious and have contributed significantly to the difficulty in comprehending the recommendations for pneumococcal vaccine. I mentioned that PCV13 to PPSV23 interval for the younger population was at least 8 weeks. And with the addition of the PCV13 for adults 65 years of age and older, that interval is now 6 to 12 months. So same dosing schedule, but different dosing intervals. So greater than 8 weeks for immunocompromised and 6 to 12 months for adults who are 65 years of age and older. And I mentioned that persons with CSF leaks and cochlear implants require 2 doses of PPSV23, and persons who have 1 dose of PPSV23, and persons with the immunocompromised conditions and asplenia require 2 doses of PPSV23. And the added layer of complexity also stems from the fact that those younger adults, 19 to 64 years of age, who receive pneumococcal vaccines, they age in to that latter group of 65 years of age and older, and their schedule will become complicated with the addition of PCV13 on top of PPSV23. So if you're a busy healthcare provider and you're trying to vaccinate your older population or persons with immunocompromised conditions, then it becomes really a tall order to get everything straight, to make sure that you're giving the right vaccine at the right time to the right person. So the figure is actually, there's very little change to the figure, but the footnotes became paramount in importance in trying to relay the message relaying the message that is simple and useful. So in effect, the 2015 Adult Immunization Schedule there's really very little change. So you can see here that the red oval, we changed that purple bar for 65 years of age and older for the PCV13 from purple to orange, and you'll note that the gap is actually a continuous line as opposed to a broken yellow line and the purple line. Vaccines for particular populations based on their medical and other conditions, that has not changed. So for 2015, the Adult Immunization Schedule, the footnotes basically revolve around the adults age 65 years of age and older by adding PCV13 on top of PPSV23. And the general set of recommendations included a certain helpful information, and one that we included was that when indicated, only one dose of PCV13 is indicated for adults. The other three points listed here have already been stated in previous versions of Adult Immunization Schedule footnotes. The interval for adults now, as I mentioned, became a little more complex with the addition of PCV13 needing to be administered for those adults age 65 years and older. So the interval between PCV13 and the subsequent PPSV23 should be 6 to 12 months, in contrast to at least 8 weeks for the same schedule for persons 19 to 64 years who are immunocompromised or have a splenia or have CSF leaks or cochlear implants. PPSV23 to PPSV23, the interval between the two, that has not changed, so we continue to incorporate that. And so, like I mentioned earlier, the bottom line is that we are what we tried to do was take the siloed recommendations or set of information in the footnotes to go from PCV vaccine specific set of guidelines, set of information to patient focused set of information. Meaning, for a busy provider, they're sitting across a patient, an individual who is so many years old, who has certain conditions. So the idea is that providers would find it easier to work with patient characteristics as opposed to specific vaccine. So these footnote changes are proposed in the 2015 Adult Immunization Schedule footnotes. So you see here that the population has been divided into three: adults who are 65 years of age and older, and adults who are 19 to 64 years with immunocompromised conditions and functional and anatomic asplenia, and other adults 19 to 64 years old with other conditions. CSF leaks, cochlear implants being one group, chronic health conditions another group, and a population that smokes cigarettes or reside in long-term care facilities. So the different this is kind of like talking about unknown unknowns and known unknowns and so on. So forgive me for playing a little bit of a mix and match game with the different combinations of the vaccines here. But for adults 65 years of age and older who have not received PCV13 or PPSV23 or has unknown pneumococcal vaccination history, they are to get PCV13, and you see here in the footnote to the footnote. I'm sorry about that. So 6 to 12 months after PCV13, right here, they should be getting PPSV23. For the 65 years and older adults who have not received PCV13 but did receive PPSV23 at age 65 or older, they are to simply get PCV13, but that should be at least 1 year removed from the most recent dose of PPSV23. Again, adults age 65 years of age and older who have not received PCV13 but did receive one or more doses of PPSV23 at before age 65, then they should be getting PCV13 that is at least 1 year removed from the most recent dose of PPSV23, followed by another dose of PPSV23 that is 6 to 12 months after PCV13, and at least 5 years removed from the most recent dose of PPSV23. If those adults did receive PCV13 but not PPSV23 at 19 to 64 years of age, then they simply get PPSV23. That's at least 6 to 12 months after PCV13. And lastly, for the adults 65 years of age and older, if they received PCV13 and one or more doses of PPSV23 at 19 to 64 years of age, they simply get PPSV23 that's 6 to 12 months after PCV13 and at least 5 years removed from the most recent dose of PPSV23. So it's basically an algorithmic approach. So the footnote is designed for the busy provider to actually identify the patient by age and by health condition and follow through a simple menu to decide what the patient needs in terms of pneumococcal vaccine. And we can obviously what I have here for persons 19 to 64 years of age but immunocompromised and with asplenia, it goes through this the possibilities of what they might or might not have received during their pneumococcal immunization odyssey. And for adults 19 to 64 years, the bottom three small bullets, there's really no change. But the idea was for us as a work group to make this easier for the busy provider to follow and make sense. And so this schedule, the adult immunization schedule for pneumococcal vaccine, the changes have been made in the footnotes. So the next steps for us is to, based on your recommendations and discussions, obviously, for us to revise the adult immunization schedule for 2015, and which will undergo another round of scrutiny by the subject matter experts, in this case specifically the influenza folks and the pneumococcal folks. And then we get the approval from our professional colleagues, ACP, AAFP, ACOG, and American College of Nurse Midwives, and like the child and adolescent schedule, we go through the clearance process and publish in the MMWR, incorporating the changes. And at the same time, we will be publishing in the Annals of Internal Medicine for hopefully in February 2015. And we'll do this in coordination with the publication of the non-influenza vaccination coverage in the MMWR. So that is all I have, and be happy to take any questions. We would certainly welcome your comments.
Thank you very much, Dr. Kim. Dr. Kissinger.
Hi, David. Thanks very much. I really like that simplified algorithmic approach that you have, but I have a plea for the committee and a question. And the plea would be first if you could simplify the interval between PCV13 and PPSV23 so there's one interval regardless of age. That would make programming our electronic decision support tools much simpler. And so I would ask that you consider deciding whether the interval should be 8 weeks at least or 6 to 12 months. Just one interval for that would be very, very helpful. That's my plea. My question is, for a 65-year-old patient who is pneumococcal vaccine naive, hasn't had either one, who then becomes immunocompromised, which schedule do we follow? Do they get just one the PCV13 and then the PPSV23 once, or do they get 2 doses of PPSV23? So that's a gap there in the.
That is not specifically identified in this slide. However, in the previous slide, we included certain general information pieces. So when indicated, only 1 dose of PCV13 is needed for adults, and no additional PPSV23 is needed if one was received at age 65 years or older.
So you might make it clear that even if they're immunocompromised, that the guidance for immunocompromised patients who are 19 to 64 does not apply to patients at 65 and older. And that may be a little confusing as to why that would change.
Thank you.
Thank you much for the comment. I don't think we're able to change recommendations from the pneumococcal by virtue of changing in the vaccination schedule. However, with Dr. Bennett sitting here and listening very carefully to your words, I think she will take it back to the pneumococcal working group for consideration.
I can make a quick comment on why this came out this way, because there was a lot of discussion about it, and we weren't happy. No one was happy. But there was sort of a weighing back and forth between making the recommendations identical versus what was going to be the most possible recommendation to implement. And the sense was that people who are immunocompromised see their clinicians far more frequently than people who are over age 65 who are healthy, and that to say a greater than or equal to 8-week interval would imply that people had to get it after 8 weeks, essentially. And the concern was that we really needed to give more leeway. So the minimum recommendation is 8 weeks, but obviously it can be extended. And we were fully aware that this was not ideal, but we will discuss it again.
Dr. Belongia.
I suspect there's an inverse relationship between complexity and successful implementation of guidelines like this. And just as maybe a rhetorical point to the extent, you can look at sort of each one at a time makes sense, but then when you look at the whole big picture, you go, oh my gosh, how could anybody sort of keep track of all this? But a more specific thing, perhaps, I wonder if it would be helpful to try and create a flow chart or a couple flow charts, one for immunocompromised and one for not, or one for under 65 and one for over, so that at least for the busy practitioner in the office, they could sort of go down the list and answer yes, no, and sort of get down to the answer quickly instead of reading all the footnotes.
If I may, we are We will be submitting a write-up of this to the MMWR for publication in February, and as I mentioned, we'll go for a simultaneous publication in the Annals of Internal Medicine. And in the Annals of Internal Medicine, we do have the opportunity to publish an algorithm that's more graphic in nature. So a flow diagram will certainly be appropriate. But given the real estate or the precious real estate on the footnotes for the adult schedule, we simply were not able to do that. But a flow diagram, I think, it makes perfect sense.
Ms. Pellegrini?
This is a comparatively minor edit, but on the 5th slide here, you have a list of contraindications for LAIV, and I suspect you pasted in the entire list. I would suggest that the 4th bullet on, are we almost there? There it is. The 4th bullet on children aged 2 to 4 years is probably not relevant for the adult immunization schedule and can be deleted safely.
Thank you.
I have just a quick question. If you can go back to the pneumococcal vaccination recommendation, the almost last slide. Actually, keep on going. Number 11. Thank you, Larry. Go back one. 2 suggestions, one from Dr. Pickering to make sure it's age 19 through 64 years in both the bottom bullet points. The second one is in terms of clinicians out there, having it in order of the likelihood of your scene. So the adults 65 and older I like on top, but followed by the adults 19 to 64 with the more common things out there. And then the more complicated maybe at the bottom, which is, again, less common in regular care. Dr. Kemp.
I was just going to follow up to the idea of a flow chart, and maybe Ray can respond to this, but in the childhood, the attempts to make all of those support catch-up documents, they did some really nice piloting with providers and found, in fact, the flow charts were really hard in general to understand compared to these kind of patient-focused things. So I think if we end up doing that, it's a really good idea to pilot them, because I thought that was really effective.
Other comment at the microphone.
Lynn Bata, Minnesota Department of Health. I know this is really a minor detail, but having already gotten some questions like, is it okay if we can give PPSV 23 2 times a year apart? Will that suffice for PCV 13 and then PSV 23? In the footnotes, you talk about adults age 65 and older, PCV 13 and PPSV 23. And while that is correct, and all of us who are here understand what that means, I think we need to be very specific. PCV 13 first, followed by PPSV 23, 6 to 12 months later. Because even when you look at the schedule, it looks like you give them both together. And I know many providers that will end up doing that.
Thank you for that comment.
Yes, Ms. Groom.
Thanks. This is a follow-up on the VA's question, and just, is the minimum interval then for a 65-year-old patient who received PCV 13 6 months to get their pneumococcal polysaccharide? So if they got it at 8 weeks, they would need to get a repeat dose? So if that can be spelled out in that lovely catch-up table in the pink book that gives you the minimum age, that's what those of us who are trying to program are trying to glean, is what is the absolute minimum interval for the 65 and older? So it is 8 weeks. Great, thank you.
Dr. Bennett.
Just to make a last comment, I think we gave you a pig's ear and you made a silk purse out of it. This has been very, very difficult, and I'm really impressed at the way you condensed all of this very complicated information into this chart. So thank you.
Dr. Schaffner.
In that same vein, on behalf of all of my colleagues on the Adult Immunization Working Group, thanks to David. He led us through this pneumococcal wilderness, and he always had good composure and a great sense of humor. So thank you, David.
Any other comment out there? And again, if there is no comment, this is also a topic that we need to vote on. Oh, wait. Do you have a comment? Oh, after the vote. Okay. Dr. Lett.
I have one other comment, and it goes back to the contraindications and precautions table, and we know that things had been harmonized in terms of antivirals to correspond with the language in the flu statement, but now there's a little bit of discordance in the use of antivirals for the other, for patients taking antivirals for the other live viral vaccines, and they're in the still in the precautions column and not the contraindications column, and so I know that Carolyn had sent me an email, literally just a few minutes ago, that that I guess not all the subject matter experts are here, and so that's probably something that might need to be discussed. Oh, Carolyn's over there now. Sorry, offline. But I don't know, like if we vote today, if that can be further clarified after the vote, or we really are voting on this language.
So just the issue is that now with the updated LAIV ACIP statement for LAIV, it now says in the antiviral use that it is, I thought that we switched the other way around. It's a contraindication for the antivirals. No, Susan, but for the varicella and zoster, it's in the other column. So it's a precaution for LAIV, but it's a contraindication for use of zoster and varicella. So we have just a difference there, how varicella and zoster virus are treated in terms of when you vaccinate based on antiviral use than we have with live attenuated influenza vaccine.
And that's concordant with the statements, correct?
It is.
Okay.
The way it's in the table now is in accordance with the published ACIP statements.
And my concern just is that it will cause confusion. That those things. I mean, there may be scientific reasons why they're not the same anymore, but people tend to keep that just in mind more easily in terms of what's a precaution, and so just didn't know if there's an opportunity for more discussion amongst the subject matter experts about harmonization for that.
Further comment, Dr. Bridges?
Yeah, I'm just not sure that if it's something that we can resolve today without those other working groups, particularly varicella and zoster, being able to weigh in.
My understanding is for the adult schedule it's a presentation of existing policy and not an opportunity to create new policy. So suffice to say, I think the work group has done a fabulous job of capturing the changes. I see Dr. Gravenstein up at the mic.
Thank you, Dr. Tempe. John Gravenstein from Merck. If you could go to the slide that says footnotes 2. There's some inconsistency. This is the first time I'm seeing this slide. So forward, please. One more. That one. Some of the bullets are written have not received X but received Y, and some are written have received X but not Y. And you may want to standardize those. And I think well, I defer to Dr. Kemp or the IAC people, the ones who deal with the actual clinicians more than I do. I think you think of it in terms of what they have received from their record, and then that tells you what's missing. So that sequence may help in the sub-bullets.
Hi.
Yes, sit back at the microphone, please.
So I also would just, I know we've talked about the dash or the hyphen, but for the footnote to the footnote, which is 1, it says 6 to 12 months after the PCV13, and I would just make sure that's clear that it's 6 to 12 months and not through 12 months, because I think some people might think after a year they should no longer give this vaccine.
Thank you.
Other comment? Dr. Schuchat.
Just about that have not received versus the has received. I think that you did a nice job with the adults over 65 first part, where the have not received PCV13 first 3 bullets are essentially almost all people 65 and over. So the majority case is being addressed first before you continue on, and it would be difficult to scan down there for the have not received PCV, but have, you know, I think it makes sense the way you did it, so I wouldn't change that.
Ms. Pellegrini.
Sorry, just a quick, I agree with Dr. Schuchat only because PCV is a single dose versus PPSV sometimes being 2. And so just from a perspective of, it's easier to think about the PCV in a binary way first and use that as your first screen before you look at whether or not they've gotten 1 or 2 doses of PPSV.
Thank you. Other comment? And again, we're being asked to consider a vote to approve this, the schedule. So is there a motion? Dr. Bennett, in a second. Dr. Riley. Further discussion. And we're keeping Dr. Freihofer online for after a vote. Okay. Other discussion? Then let's go ahead and go, we'll go counterclockwise this time, starting with Dr. Karen.
Karen, yes.
Belongia, yes.
Dr. Belongia, you failed your first test here, so.
Okay, I need the remedial on clockwise versus counterclockwise, and I'll take that module soon.
Okay, but that's okay. Why don't we continue with Dr. Kemp?
Kemp, yes.
Riley, yes.
Bocchini, yes.
Vasquez, yes.
Reingold, yes.
Pellegrini, yes.
Tempta, yes.
Bennett, yes.
Rubin, yes.
Romero, yes.
Harrison, yes.
And the
Belongia, yes again. That's not 2 votes, but just.
And I'll remind you, this is not Chicago. Okay. But no offense to anyone from Chicago here. The motion carries 13 votes for, no votes against, and again 2 absent from voting. So this passes. And we thank the adult work group for a very complete and succinct presentation. And with this, I guess we move on to the hepatitis. What? Oh, I'm sorry, Dr. Freihofer.
Thank you. Well, on behalf of the American College of Physicians, the nation's largest medical specialty society representing over 141,000 doctors of internal medicine, medical students, residents, fellows, and on behalf of our patients, we want to thank the ACIP for voting on this new adult schedule. And I want to also give a special thanks to the working group for putting together the new pneumococcal mega footnote, but I really do prefer the new title, ACIP's A Pneumococcal Odyssey. with the goal being to help practitioners more easily implement this new schedule. As we all know in this room, pneumococcal infection is a major cause of morbidity and mortality and kills as many as 4,000 people in the U.S. each year, mostly adults. And older adults are at increased risk for invasive disease, and doctors of internal medicine provide regular care to the majority of patients affected by this new recommendation. So you've done your work, and now it's in our hands. And just to let you know, we will be stepping up to the plate to help get the word out about this new schedule. We have an adult immunization committee which meets regularly. We're open to new ideas, to new partnering, but here are some of our current plans. We have a dedicated immunization portal, and we will be updating all of our immunization materials and programs. And this includes our adult immunization app and our adult immunization guide. We also have several ongoing quality improvement immunization initiatives, including a CDC-funded QI program, as well as a new I Raise the Rates program. We also plan to have a special coaching call on pneumococcal vaccination for these programs. As you heard, the new schedule will be published in February in the Annals of Internal Medicine. And just to let you know, the most recent impact factor for Annals is 16.104, which is the highest of any specialty journal in the Thomson Reuters General and Internal Medicine category. This new recommendation is both comprehensive and complicated, but our patients will benefit from our collective immunization implementation efforts.
Thank you very much. Dr. Strickis.
Just a quick announcement. I don't believe it's been announced at the meeting, and I take advantage of the courtesy afforded by Drs. Kimberly Hagan and Dr. Walt Ornstein from Emory. The Emory Vaccine Dinner Club is meeting specially tonight, and they're having Dr. Stanley Plotkin speak of blockades and barriers, impediments to vaccine development. And if anybody wishes to go, it starts at 6:30. Latch on to your favorite CDC or Emory person, and we'll take you over there. Thank you.
Thank you very much. Okay, if we can move then to Dr. Reingold for introductory comments on the hepatitis A vaccine. Do you want a break?
So thank you. Before I get to hepatitis A, I just wanted to update people one quick thing about the discussion this morning about pertussis vaccine in pregnant women. We've had an email from Dr. Schechter, who's in charge of immunizations for the state of California, informing us that in fact the vaccine is covered by Medi-Cal in California and has been for some time. He acknowledges that a lot of our providers have problems getting reimbursement for vaccination, as well as a lot of other problems with Medi-Cal, but it is in fact covered. So that's just a brief update from what you heard this morning. I also have the pleasure of chairing the hepatitis A working group, and we're going to have a report this afternoon from Dr. Nelson about where we are as a group. I'm going to actually skip ahead for a minute here. These slides got a little out of order. So first of all, this is simply to acknowledge again that we have a robust working group with representatives and consultants from a variety of areas. And again, Dr. Nelson from CDC here certainly is doing the lion's share of the work on behalf of the working group, and I'd like to thank her for that. And also just to acknowledge that in addition to Dr. Nelson, a variety of people in the Division of Viral Hepatitis have been intimately involved in helping the working group. Now just to go back. So this is simply to remind you that the working group has basically been tasked with updating the recommendations around the hepatitis vaccines, both A and B, and we've decided to go in alphabetical order, so we're working on hepatitis A at the moment. And that there have been a variety of statements concerning hepatitis A and hepatitis A vaccine previously. As I'll remind you what the terms of reference are in a minute, but since the June meeting, we have had a number of telephone conference calls focused on hepatitis A vaccine coverage and burden of disease, and the presentation today is largely going to focus on hepatitis A burden of disease and the population that still may require protection. So basically, as it says here, in the short term, we're discussing updating the hepatitis A vaccination statement, talking about what types of activities might potentially be useful to try and improve coverage with the vaccine, and whether or not catch-up vaccination for older children might be worth considering. And in the long term, also discussing the question of post-exposure prophylaxis in adults over the age of 40. I think when you see Dr. Nelson's presentation, you'll see that while the burden of disease from hepatitis A is certainly much lower than it used to be, there are still gaps in immunity, and particularly with the increase in importation of foods that pose a risk of hepatitis A infection, that we really have not quite finished the job. But anyway, Dr. Nelson.
Thank you, Dr. Reingold. I'm going to give an update on hepatitis A disease burden and hepatitis A population protection. The outline of the talk is hepatitis A vaccine history in the United States, epidemiology, vaccine coverage, antibody to hepatitis A viral seroprevalence, hepatitis A outbreak and food-associated exposure risk, and a summary. Hepatitis A vaccine was introduced incrementally in the United States. In 1996, vaccine was recommended for children at age 2 years in communities with high rates of disease, and for children through teen years in outbreaks. In 1999, vaccine was recommended in 11 states, shown in dark purple, and in 6 states with rates above the national average, shown in light white. In the 11 states, the rate was 2 times the national average, or greater than or equal to 20 cases per 100,000 population, where in the 6 states, the national average was greater than or equal to 10 cases per 100,000. In 2006, universal childhood vaccination was introduced. It was recommended for use at age 12 to 23 months in all states. And it was recommended that vaccination programs for ages 2 to 18 years be continued. Catch-up vaccination should be considered in outbreaks in areas with increasing disease rates. And vaccine was also recommended for any person wishing to obtain immunity. Of note, no routine recommendation was made for children aged greater than 23 months. In addition, vaccine is recommended for groups at increased risk of hepatitis A viral infection or severe disease, such as travelers, men who have sex with men, users of injection and non-injection drugs, persons with clotting factor disorders, persons who work with non-human primates, persons who anticipate close personal contact with an international adoptee, and persons with chronic liver disease. Vaccine is also recommended for post-exposure prophylaxis for healthy persons aged 12 months to 40 years. Now I'm going to talk about hepatitis A epidemiology. Data collection for hepatitis A started in 1966. The highest number of hepatitis A cases reported was in 1971, where there was approximately 60,000 cases at a rate of about 30 cases per 100,000 population. In 1996, as mentioned, vaccine was recommended. There was about 31,000 cases at that time, decreasing in 2011 to about 1,398 cases. The rate also decreased during this time from 11.7 cases per 100,000 population down to 0.4 cases per 100,000 population. This represents, from 1996 to 2011, a 95.5% decrease in reported cases. This slide shows the number and rate of reported cases of hepatitis A from 2008 to 2013. As shown in the previous slide, in 2011, the number of reported cases in the United States reached an all-time low of 1,398 cases. In 2012, the number of reported cases in the United States increased to 1,562 cases, representing the first increase in cases since 1995. In 2013, the number of reported cases in the U.S. increased again to 1,781 cases. Though these increases are not large at this point, and most of the increase in 2013 is attributable to a multi-state hepatitis A outbreak, which I will describe later, the increases from 2011 to 2013 represent a reversal of a trend of almost over 2 decades. We have initiated exploring the etiologies of the case increases, including reporting biases, and exploring the geographic distribution of the cases, as I will show on the next slide. This slide shows the rate of hepatitis A cases by U.S. region in 2011 to 2013. Increases in the rate of cases from 2011 to 2012 were reported in 4 regions. Increases in the rate of cases from 2012 to 2013 was reported in 6 regions, with a decrease in 1 region. The multi-state outbreak in 2013 was reported primarily in the Mountain and Pacific region among 8 states. However, increases from 2012 to 2013 were observed in other regions as well. When looking at these data at the state level, it was observed that some of the increases in rates occurred in states not involved in the outbreak, suggesting multiple causes for the increase in number and rate of cases. This slide shows the age distribution of rates of reported hepatitis A cases from 2007 to 2012. Rates of acute hepatitis A declined for all age groups from 2000 to 2012, though only 2007 to 2012 are shown here. Rates were similar and low among persons in all age groups in 2012, at less than 1 case per 100,000 population. In 2012, rates were highest for persons aged 20 to 29 years, about 7 cases per 100,000 population. That's the top line shown in yellow. The lowest rates were among children aged less than 9 years at 0.15 cases per 100,000 population, as shown in the bottom light blue dashed line. Starting in 2007, children less than 9 years of age had the lowest rate of infection in any age group. The Healthy People 2020 target is 0.3 cases per 100,000 population. Only the 0 to 9 years age group has declined to a rate lower than 0.3 per 100,000. Of note, the rates increased from 2011 to 2012 for ages 20 to 29 years and ages 40 and above. Looking at the data separately by decade of life for children, 0 to 9 years and 10 to 19 years, and all adults aged greater than or equal to 20 years from 2008 to 2012, it is clear that the largest percentage of hepatitis A cases are occurring in adults. Taking a further look at burden of disease, a recent paper by Collier et al. Analyzed hepatitis A hospitalization trends from 2002 to 2011 using primary discharge diagnosis data, ICD-9 codes, from the national inpatient sample. Though a decrease in hepatitis A hospitalization rates was observed overall from 0.72 per 100,000 in 2002 to 2003 to 0.29 hospitalizations per 100,000 in 2010 to 2011, the mean age of persons hospitalized for hepatitis A has increased significantly over the study time period. the mean of 37.6 years of age in 2002 to 2003, compared to 45.5 years in 2010 to 2011. This table shows information from case surveillance, or National Notifiable Disease Surveillance System, data regarding hospitalizations and reported hepatitis A cases. The first column shows hepatitis A cases reported, the same numbers as shown on previous slides. The second and third columns are the number and percentage of cases with available data on hospitalization. As can be seen, many cases are reported without hospitalization information. 35 to 45% of cases do not have data on hospitalization from 2009 to 2012. Therefore, cases hospitalized is likely underestimated. In the last two columns, cases hospitalized, the number and percentage of cases hospitalized is shown. 39.3% of hepatitis A viral cases were hospitalized in 2009 and almost 46% in 2012. So since 2009, hospitalizations have been increasing. Though hepatitis A hospitalization rates have decreased overall, as shown by the National Inpatient Sample, primary diagnosis code data, surveillance data shows that hospitalization rates for all reported hepatitis A cases increased from 39% in 2009 to 46% in 2012. Looking further back, these data, this trend of increasing hospitalization rates for reported cases has been observed since 2005. In 2005, the rates were 33%. Looking at hepatitis A deaths from 1990 to 2012, we can see that deaths have declined since vaccine introduction for all age groups. The number of deaths now approaches zero for age groups less than 50 years. The total number of deaths in 2012 was 23, with 21 deaths in the 50-plus group and 2 deaths in the 20 to 49-year age group. These numbers increase slightly when multiple causes of death are considered. So who is getting infected with hepatitis A? Patients were asked about engagement in selected risk behaviors and exposures during the incubation period, which is 2 to 6 weeks prior to onset of symptoms. Data were collected as part of CDC's NNDS system via passive surveillance, which is voluntary reporting from state health departments. Of the 1,562 case reports of acute hepatitis A received by CDC during 2012, a total of 568, or 36% of cases, did not include a response to any questions about risk behaviors and exposures, making assessment of risk behaviors or exposures challenging. Of the 994 case reports that had a response, 80% indicated no risk behaviors exposures for hepatitis A, and 20% indicated at least one of the risk behavior exposures for acute hepatitis A during the 2 to 6 weeks prior to onset of illness. Of those with identified risk factors, travel was the most identified, and direct contact was second. Of the 713 case reports that had information about travel, about 13% involved persons who had traveled outside the United States and Canada. Foodborne or waterborne exposures were reported as less frequently. However, foodborne exposure is a growing area of concern and may represent a percentage of the cases with no risk factor identified. Because risk factor information is often missing, in other words, no response to a risk factor is given when cases are questioned, select health departments are funded to conduct enhanced population-based surveillance. An analysis of these data done by Clevens et al. Looked at data from 2005 through 2007. They looked at 6 emerging infection programs, or EIP sites, covering an estimated 30 million population. This graph shows the risk factors reported by cases in the EIP sites during this time period. There are less missing data in funded sites compared to the NNDSS data. However, the distribution of risk factors was comparable. Travel was still the most frequently reported, but 47% of cases with a positive response, including persons with direct international travel and those who had contact with someone who had traveled. This is much higher than the approximately 13% reported by passive surveillance, and much higher than observed in the 80s and 90s, about 4%. Molecular characteristics of a sample of cases confirmed they were travel-related. The strains were related to Mexican and some Brazilian hepatitis A viral strains. Though these data are from 2005 to 2007, it is believed that the data are similar today. Of note, over 35% of cases, as shown in the last column, are reported an unknown risk factor. Foodborne exposure may represent a percentage of these unknown exposures. However, based on data collected by both the NNDSS and the EIP hepatitis surveillance sites, no significant association between risk factor and the increase in hepatitis A cases from 2011 to 2013 can be made at this time. Hepatitis A vaccine coverage. The wider use of vaccine is largely responsible for the marked decrease in hepatitis A morbidity. However, vaccination rates remain low. Hepatitis A vaccine is recommended in a 2-dose series. In 2012, hepatitis A vaccine coverage for children 19 to 35 months of age was 81.5% and 53% for greater than equal to 1 and greater than equal to 2 doses, respectively. This is substantially less than the Healthy People 2020 target of 85% for 2-dose coverage level in this age group. In 2012, coverage among adolescents 13 to 17 years old was estimated to be approximately 60% and 48% for greater than equal to 1 and greater than equal to 2 doses, respectively, based on preliminary data. Only greater than equal to 3-dose HPV vaccine coverage has lower teen coverage than 2-dose hepatitis A vaccine. Of the adolescent vaccines routinely recommended, there is no hepatitis A recommendation for children greater than 23 months, while HPV, Tdap, and meningococcal are routinely recommended for adolescents. Greater than equal to 2-dose coverage for adults aged 19 to 49 years is 12.5% overall. The vaccine coverage for persons with chronic liver disease, a high-risk group, is 17%, and vaccine coverage is 20% for travelers outside the U.S. to countries other than Japan, Australia, New Zealand, Canada, or other countries of Europe. Therefore, the age groups with the highest death rate have the lowest vaccination coverage. This data source is National Health Interview Survey, collects information on health and healthcare of the non-institutionalized civilian population in the United States using a nationally representative sample. Antibody to hepatitis A virus seroprevalence. The change in prevalence of antibody to hepatitis A virus by age group is shown for 1999 to 2000 in light blue, and 2009 to 2010 in dark blue. Significant increases, as indicated by the asterisks, occurred in the proportion of children with protection for ages 6 to 11 years and 12 to 19 years. This is most likely due to vaccination. A minimal change occurred in prevalence among adults 20 to 29 and 30 to 39 years. However, significant decreases occurred in the proportion of adults with protection for ages 40 to 60 years and older. Overall, the prevalence of antibody among U.S. residents remained about the same between the two surveys, at 39 and 35% respectively, indicating that only 1/3 of the U.S. population had protection against hepatitis A infection in 2009 to 2010. The lowest prevalence of antibody was among adults. A multi-state hepatitis A outbreak occurred in the United States in May 2013. The outbreak was associated with contaminated pomegranate arils imported from Turkey and illustrates ongoing hepatitis A exposures and adult susceptibility. There were 165 cases in 10 states. 8 of those were in the western states. Most, or 93% of cases in the outbreak, were ages greater than or equal to 18 years. Overall, 44% of cases were hospitalized, and 45% of adult cases were hospitalized. 2 cases developed fulminant hepatitis, and 1 required a liver transplant. In addition, multiple recent berry-associated outbreaks in Europe have been reported. Of note, the percent reported hospitalized in the outbreak, 44%, is very consistent with the percent of hepatitis A cases hospitalized in 2011, based on case surveillance data, where 43% of cases were found to be hospitalized. This slide shows the trend in U.S. imports of fruit and vegetables. Though based on surveillance data, travel is the most reported risk factor for hepatitis A, there is a growing concern about the risk of exposure from contaminated food. The volume of imported fruit and vegetables in the United States has increased from 1999 to 2013. Last year, the U.S. imported over 12 million tons of fruit and almost 9 million tons of vegetables. Imported fruit and vegetables originate from countries where hepatitis A is endemic. And note on this slide that Turkey is not one of the countries listed. Mexico import most of the food. And if you look on the next slide, this shows the estimated prevalence of hepatitis A virus based on a study done in 2005. The dark green and moderate green are the intermediate and high endemic countries. And as you can see, Mexico and South America are both considered intermediate endemic countries. So in summary, an increasing proportion of adults in the United States are susceptible to hepatitis A. This is due to reduced exposure to hepatitis A virus early in life, significant decreases in the antibody to hepatitis A viral seroprevalence in older adults, meaning adults greater than or equal to 40 years, low-dose vaccination coverage among adults, including high-risk adults, travelers, and those with chronic liver disease, for example. And as mentioned, morbidity and mortality increases with age. There's also suboptimal hepatitis A vaccination 1- and 2-dose coverage among young children. Increases in hepatitis A viral cases, as noted, have occurred in 2012 and 2013. These are the first increases since 1995 and 1996. In addition, hepatitis A viral infection rates have increased from 2011 to 2012 for ages 20 to 29 years and ages greater than or equal to 40 years. The mean age of hospitalizations for persons for hepatitis A has also increased significantly from 2002 to 2003 to 2010 to 2011. And hospitalization rates for reported hepatitis A cases have increased from 2005 to 2011. Hepatitis A virus remains endemic in many areas of the world, provides a risk for travelers to intermediate and high endemic countries, as well as a risk for consumption of imported hepatitis A viral contaminated food from global sources. Of note, herd immunity does not protect against foodborne exposure. And as mentioned, there's no routine or catch-up hepatitis A vaccine recommendation for adolescents or adults. The hepatitis A ACIP Hepatitis Work Group is currently focusing on updating the hepatitis A vaccination statement, which was last released in 2006. The work group is also discussing strategies to address the increasing number and rate of acute hepatitis A cases and continuing progress toward the Healthy People 2020 goal of 0.3 cases per 100,000 population. The work group is discussing catch-up vaccination for children and teens aged 2 to 18 years. Justification for expanding the age range of childhood vaccination to 18 include continuing exposure to hepatitis A virus, future protection of the adult population, since an increasing proportion of U.S. adults are susceptible, and to maximize herd immunity from childhood vaccination. The working group is also discussing other strategies for catch-up, such as vaccination for other ages. Additional information and evaluation of the evidence is needed before work group consensus can be reached. Oops. Additional information that would be helpful in support of expanding the age range for universal hepatitis A vaccination include modeling hepatitis A disease and cost effectiveness with higher hepatitis A vaccination coverage among children and adolescents and or subsets of adults. Planning is underway for such a study. Grade for hepatitis A 1 and 2 dose vaccine efficacy, safety, and long-term protection. A systematic review is in progress. And as evident from the multi-state outbreak, study of hepatitis A vaccine immune response 2 weeks after first dose to consider vaccine for post-exposure prophylaxis among adults aged greater than 40 years is important. Planning is underway for such a study as well. I would like to thank the Division of Viral Hepatitis, NCIRD ISD, and the ACIP work group for their contributions.
Thank you, Dr. Nelson. Open for any questions here. Dr. Karen.
So I have a couple of questions around the second dose. And the first question I have is back to the slide 21, when you talk about incomplete coverage, particularly, say, in travelers. I suspect, given the interval between first and second doses, that there are many travelers who go to travel clinics shortly before they travel, get a dose, and then never return. And so I was wondering, my first question is, so for those sort of dismal data, do you have coverage information for, say, 1 dose as opposed to 2 doses in travelers?
I do not have the 1 dose based on this survey.
Okay, and then my second question has to do with what we understand about the protective efficacy of 1 dose versus 2 doses. The teaching that I had always learned was that we give 2 doses to sustain immunity, but that in fact, very often you achieve protective levels of antibody after a single dose, and I just wanted to check if that understanding is correct.
Yes, and there's some protective immunity after 1 dose. Studies of delayed booster dose in people over 2 years of age have shown that up to 31-month delayed booster, you have comparable results. In terms of one dose efficacy, in Argentina, they have a 1-dose universal strategy, primarily based on children, and there's 5 years of follow-up data right now. So that's all we have right now. And we know for 2-dose that modeling long-term protection, we believe is at least 25 years or more.
Dr. Rengold.
Yeah, I think Noel has it right. Actually, when I was on SAGE, we based on the Argentina data, basically gave countries a permission, if you will, to go with a 1-dose schedule if it's all they could afford. So I think the data are quite convincing that 1 dose is highly efficacious, but the duration of protection is obviously somewhat uncertain.
Dr. Kemp?
Yeah, I had a question about the use of catch-up here, because, I mean, on the schedule, it's recommended for catch-up now after 2, all the way up through adolescence, right? I mean, it's not...
It's to be considered, sorry. Catch-up can be considered.
I don't know, in all those catch-up things, isn't it? It gives you the minimum age of 12 months, and then it says dose 1 to 2. I don't know. I guess, I mean, I agree that education and focused encouragement of that needs to happen, but is that actually not part of the schedule right now?
I guess.
The schedule is for 12 months to 23 months. And then, as the recommendation is stated now, catch-up can be considered.
Dr. Bennett?
Just a quick question in considering strategies. You showed us some data from the EIP about the potential source of infection or risk factors. I wondered if we have any ability to look at those data by age. Yeah, that was it right there.
This one.
Do we have data by age, or is this is all ages, correct?
Yeah, this is all ages. I'm not sure about that.
It would be helpful to break it down by age to identify the most the potentially greatest strategies for decreasing the rates of disease.
Yeah.
Dr. Scheffner.
Thank you, Dr. Nelson, first for a very nice presentation. And to follow up on Nana's point, I'm particularly interested in the unknowns. I wonder what the age and sex distribution of that group is.
Yeah, I don't have that, but thank you. It's an important point. And the unknowns in this survey and the other are quite high. So we're looking into looking back at these analyses now currently to try to get at try to further define what this group is, but I don't have these data right now to present. Thank you.
Dr. Gorman?
So my questions deal with the reporting issues. This is a reportable disease. Do you have any idea of how underreported it is?
Well, in children, children are usually asymptomatic up to five years. We've right now in Division of Hepatitis report we're 2 times, estimating about 2 times.
So maybe I can hone that question down to be one that's actually answerable. Is there a difference between your spontaneous reporting and your augmented reporting on the EID centers? Is there a difference in the rate of hepatitis reporting between those two groups?
Not that I'm aware of.
Yeah. The reason I ask that is because if we've had a 95% reduction, and now while it does look like it's trending up slightly, it may be that we're just bumping along the bottom. And what has occurred is as the disease becomes rarer, people are more likely to report it because it's unusual. I'm not saying that is what is happening, but it's a concern that I have. And the second thing I would do, and this is from an unscientific survey of 3 adult children between the ages of 20 and 29 who happen to share my last name. All 3 of them have traveled to high-risk countries, whereas I think, and that may be a much more common event in the generation between 1995 and 2012 than it was in the generations beforehand. So the increase may be, in fact, that they're exposing themselves to more risk factors rather than there's some other vaccination-related episode.
Thank you.
Similar type question. I'm curious as to what we know in terms of the patients with more severe disease and hospitalization, and how many of them have chronic liver disease as a risk factor. The last figures I saw is we do an atrocious job of immunizing patients with chronic hepatitis C and alcoholics with chronic liver disease and having them covered. But I'm just curious about how much that cohort contributes to the severe cases.
I'm not sure how many of the severe cases are in chronic liver disease. We have looked at transplants, and we do not see a trend over time. I'm trying to get to that slide here. Here it is. So this is looking at liver failure and liver transplant in hepatitis A cases from 2002 to 2011, and really the numbers sort of go up and down over time. But that's like one of the best That's the way I can answer that question right now.
Ms. Pellegrini.
Dr. Reingold and I were just discussing the fact that another barrier for this group, noting that travel is the single greatest identified cause, is that, again, travel vaccines tend not to be covered by health insurance. So even if you think, gee, maybe I should get a vaccine before I go to Mexico, which I think actually most people don't in traveling to some of these countries, you're going to have a hefty cost out of pocket.
Dr. Pickering.
Yeah, to follow up on what Dr. Kemp said a minute ago, at age 2 on, the range of recommended ages during which catch-up is encouraged and for certain high-risk groups. So it's not recommended routinely for 2 and over. So that way of handling things does not seem to be working because kids aren't getting immunized. And then adults who develop these conditions after they get to be adults, drug use and so on, what percentage of them are immunized? Hepatitis B, hepatitis C, very low percentage of them are immunized against hepatitis A. So hopefully you're considering that point that's on the schedule as to perhaps changing it to a more stronger recommendation rather than should be encouraged.
Other comment? Okay, thank you, Dr. Nelson and Dr. Reingold. Dr. Smith, is Dr. Kroger coming back tomorrow morning? Yeah. Okay, tomorrow morning. So he was our last hope of extending the schedule out for another 45 minutes or so, and seeing that, last call, we have not had any registered public comment, but I'm looking to the back table if there is any. And I see none. So I think I'm, Dr. Ornstein.
Yeah, I just wanted to say that Ray Strickis had mentioned the Emory Vaccine Dinner Club. It actually has wine and cheese at 6, and then the talk is at 6:30. And it's in the School of Medicine building, if anybody's interested, which if you walk down Clifton Road, it's the second building on the right after you cross the railroad tracks.
Thank you very much. And I would be remiss in 2 other announcements. First, I was informed by Dr. Gemmel that this is also NACI's 50th anniversary. So congratulations to our cousins to the north. And if you didn't notice on Google yesterday was the 100th birthday of Jonas Salk. And so Google had a very nice graphic in commemoration of that. So with that, I think we stand adjourned for the afternoon, and we'll be picking it up right at 8 o'clock tomorrow morning. Thank you.